I cannot, my slides are not moving. Let's see if I can get this back. I apologize. There we go. I'm on my laptop. Okay, it all began back in London of 2012, where a group of us got together to talk about common challenges facing nursing. And we discovered that we had many similarities and differences. And in this group were nurses representing countries, low, middle income, and high income countries. And we come from this group, we really discovered that there's a need for support and resources to deliver safe nursing care. And from that came the 6 baseline nursing standards. Many of you have seen these slides before. You saw them as my computer was not working very well this morning. But they include staffing based on acuity. You could see the staffing ratios here, non-rotation of nurses off the unit, formalized education or orientation, including 2-week period minimum, and then clinical experience on the unit with verification of competency. Continue education is very important. We came up with a recommendation of 10 hours per year. Multidisciplinary teamwork as nurses as core members of the pediatric oncology team. Safe delivery of care is so important as well, including that for our staff, patients, and families, but also handling chemotherapy with PPE and other equipment needed to protect against hazards and infections, and then delivery of care based on nursing policies and procedures to guide the delivery of care using evidence-based practice. Many of you have seen these slides, this timeline, but from this initial workshop and the work that was done by Sarah Day and group, article or a manuscript was published in Lancet and then Cancer Control. We started developing our baseline nursing standards task force in 2017, and that was kicked off with a leadership advocacy workshop pre-Congress in Washington. Then followed by the development of an advocacy toolkit, which is on the website. We had keynotes. We have many presentations over the years at SIOP. And we also have focused on my computer just froze again. We also have focused on research, advocacy, and implementation. We have a 5-year plan, but what I want to do as I end is highlight some of the research following our initial publications, looking at disparities in delivery of care, particularly a survey, an international survey that was done. We also followed with predictors of hospital non-achievements of these standards, a validation of a tool, and then more recently, in the last 2 months, we have published a decade of our achievements, international pediatric oncology baseline nursing standards in pediatric blood and cancer. So I'm going to turn this back over to Miriam. This is our current SIG, and thank you for putting together this webinar today.
Thank you, Linda, for that. I think some people were wondering what are the baseline standards, and you really kickstarted us off to know what exactly in the standards, what was the thinking behind developing the 6 standards that have impacted pediatric oncology in many countries, over 20 countries where this has been already implemented. And already there is an improvement in patient care in these settings, as is going to be demonstrated with the panelists on this webinar. To kickstart us, I'm going to invite Dr. Glenn Mbah. Glenn needs no introduction. He's a champion of nursing, an advocate, And he's done a lot of work in low and middle income countries in pediatric oncology nursing. Now, Dr. Glenn, when you were implementing the baseline standards, what was your focus? Which standards did you focus on mainly? And what has been your experience in implementing the standards in your setting?
Thank you, Miriam. Thank you for your generous introduction. I'll start by saying the baseline standards has been a blessing because it's really a collection of what we want to see in terms of practice or care provided by nurses to patients to children with cancer. And in addition to that, the baseline standards special interest group has over the years, as Linda showed, developed this toolkit, which includes not just the standards, not just the subcomponents of each standard, but also how you can advocate, and there has been actual active advocacy related to the standards with a lot of endorsements from some major pediatric oncology hospitals, some major global actors, including charities and non-governmental organizations that support care for children with cancer. And with all this, it has really assisted or enabled some of us to make progress locally, because we are now showing that this is a set of standards that were developed by an expert panel. It's a set of standards that has been validated, that has been approved, that has been endorsed by all these global partners, including SIOP, the International Society of Pediatric Oncology. And so it's been easier to navigate local administrative challenges to see that some of these standards are recognized and implemented. One of those standards which we've seen success with has been, particularly for me, has been standard 2, which calls for formalized training in pediatric oncology at the start of practice in a pediatric oncology unit for every nurse. Previously, before the standards, we've been seeing a phenomenon where nurses are assigned to pediatric oncology unit, and they happen to learn on the job either from the oncologists or from experienced pediatric oncology nurses who are there, and from the patients as well. But with these standards and the clear guidance that it provides, courses have been developed that provide foundation training before any nurse can enter the pediatric oncology space. And with the training that institutions invest in, it stimulates them or it motivates them to keep these nurses in place and not rotate them. This standard spells out clearly, I like to read it. Formalized pediatric oncology induction program to include 2 weeks of theory and clinical skills training, followed by 3 to 4 weeks spent with an experienced nurse preceptor. The induction program should include specific learning objectives. Evidence of successful completion should be obtained before new nurses provide direct patient care. And the content is spelled out, and it says we need to assess competency. The Sub-Saharan Africa Nursing Network, in collaboration with SIOP Africa and World Child Cancer, a couple of years back, developed a foundation training package, which over the years, and it got endorsed by SIOP Africa, over the years, we have trained colleagues to deliver this training package for nurses in their units who are new to pediatric oncology. We've successfully trained trainers for this package for West Africa, several countries in West Africa, including Nigeria, Ghana, Cameroon. We've trained colleagues from Eastern Africa. We've trained colleagues from Southern Africa to be trainers for this package, and they have gone on to train their own colleagues who are new in the service. And an important component of this package is the competency assessment, which enables senior colleagues and the new colleagues to see their own progress in the pediatric oncology service. and see where they need to make more efforts. In Cameroon, where I practice, we've applied this training manual, this training course, and we've used it to increase the number of nurses that have been assigned to pediatric oncology. Once we've requested from hospital administration, give us nurses to train, we train the nurses, we show them the competency, and they can be assigned to this unit. And once they are assigned, it becomes difficult for rotation because the institution has invested in their training. That's one of the standards where we've seen good progress with implementation. The next standard I would like to talk about is standard 4, which says nurses are recognized and acknowledged as core members of the multidisciplinary pediatric oncology team, evidenced by inclusion in patient rounds and all meetings with patients, parents, caregivers, when the diagnosis and treatment plans are discussed. When we did the assessment, the global assessment, and showed disparities with regards to this baseline standard in 2019, we saw that 41% of nurses in low and lower middle income countries did not participate in important decisions or discussions related to patient diagnosis and treatment plan. I'll give you an example. In Cameroon, we took this standard and our oncologists have been very receptive of it and they have been willing to implement it. We now have across 4 centers what we call weekly multidisciplinary team meetings, virtual. And with these meetings, it is the nurses that present patients, updates of patients, weekly updates. We have other MDTs where the oncologists present the patients, but for this weekly update, it's the nurses that present the patients. They know which patient should have come, which patient has not come. They know which patient came and got what therapy and what effects the patient had. So they present the patients and then the patient is discussed by the whole team, including the oncologists, the radiologists, the pathologists, and they are well involved and feel responsibility over the treatment and management plans for these patients. Another example I would like to cite is this baseline standard 5, which states that nurses should have the resources needed to provide safe pediatric oncology care, including intravenous pumps, hand washing, sanitizing supplies, and isolation supplies. It says that nurses should only prepare chemotherapy when there are no pharmacies. We took this baseline standard and looked at it. Again, from the last survey in 2019, we saw 63% of nurses in low and lower middle income countries were mixing chemo, irrespective of whether there was a pharmacist or not. So how could we make a change with this? In our hospital, one of our hospitals in Cameroon, we saw that, yes, we don't have sufficient clinical pharmacists, but we do have pharmacy technicians. And then we thought if we could train them, involve them in the baseline nursing training, first of all, and then add as an additional chemotherapy and biotherapy training to them, we could transition the reconstitution of chemotherapy from the nurses to the pharmacy technicians. We've tried this for the last 1 year, and we've hit that mark where the nurses no longer reconstitute chemotherapy. It doesn't end there. We have put in place SOPs, standard operating procedures for reconstitution, for checking, for administration of chemotherapy. And now we have audits that we are conducting to see what change it has made in the number of chemotherapy medication errors. So we will have more information about the success of this pilot in due course. But these are just practical examples which we've been able to, achieve. I could even go further to talk about the bigger scale achievement with the standard 2 on foundation training, where in Ghana we have seen with a lot of advocacy, and notably from pediatric oncology champions that are there, like Professor Rehana, and also the World Child Cancer team. They've been able to successfully set up an associate membership course for nurses in pediatric oncology with the Ghana College of Nursing and Midwifery. And they incorporated the recommendations of the baseline nursing standards into that course curriculum. All the topics that were recommended to be covered have been, included in that curriculum. And I just want to say these are just examples of how far we can go by using these baseline nursing standards, which have been endorsed and which continue to be, researched upon and modified, and hopefully we can continue to gather evidence on how impactful they can be. Thank you, Miriam. I'll answer more questions if you have.
Thank you so much, Glenn, for that really explicit examples of how the baseline standards have impacted in Cameroon, and not only Cameroon, but all over Africa, how you've been able to take this knowledge and transform it into something tangible that is on the ground and can be felt by everyone in the area that you practice. And I know some people have questions, but we can put the questions in the chat box, or otherwise at the end of the panel discussion, we shall be able to open up the discussion to the audience, and then the questions can be asked then. So thank you, Glenn. Now moving on to our second panelist, I would like to invite Dr. Liliana Vásquez. Now, Dr. Liliana is a consultant with PAHO. So this is to demonstrate that not only are these standards just implemented by nursing, but Liliana has done a great job of how she has incorporated these standards up to the level and even into the National Control Plan for Childhood Cancer in Peru. Over to you, Dr. Liliana.
Thank you, Marianne, and thank you, Rehana and Glenn, for sharing this wonderful experience, and thank you for inviting me to this webinar. I just put up some slides a little bit to mention how we have been working with the standards in Latin America, and particularly in Peru, to open a little bit the discussion. I think it's important after several years to acknowledge all the work that this has been part of the global initiative for childhood cancer in our region and in Latin America, and also in countries like Peru. As I was mentioned by Glenn, I think there's a most valuable impact that we need to reflect on, and we need to comment and discuss later on, perhaps if you have questions or queries. So I would like to briefly mention two aspects that I think are important. One is how the SIO baseline nursing standards have impacted or are being implemented at the regional level, and also in a country specific like Peru. First, as you know, at PAHO, we are working within this framework of the Global Initiative for Childhood Cancer that give us the global mandate of increasing the survival rate for children with cancer, children and adolescents with cancer, but also with quality of life. And one of the main purpose of the work, and here is Kearney, Julia, many of the colleagues that have been part of this integration of nursing to the center of the GACC activities, particularly in Latin America, with this great work that has been part of many interventions from St. Jude Global, from Sick Kids, and many other collaborators. So we try to, at the regional level, to highlight the potential of empowering a regional nursing working group since 2021. With the specific objectives to develop a situational analysis, a scope of practice for pediatric oncology nursing in Latin America, to provide and develop also case studies from our work, from the work from our countries, and also to support, of course, collaborative initiatives and the SIO baseline nursing standards, and to integrate these standards into policies that could be available in Spanish or in Portuguese in countries that need it most. So at the regional level, we started from 2021 into several phases of work. One was this needs assessment, situation analysis, and this was pretty much a standard for all working groups that are still working with us at PAHO and the Global Initiative for Childhood Cancer, also the development of several resources or global goods, and finally the dissemination of this analysis. Based on this situational analysis in the region, many experts, nurses from different countries gathered to create some of the prioritization of activities and opportunities for the region. And this led us to develop this important resource named the Scope of Practice, that was part of also a suggestion from Julia, from Kearney, from many other mentors that we had at this point, from Moni, Sarah, Lisa, many of the colleagues that kindly help us with these activities to publish this research that not only included a situation analysis of the scope of practice of pediatric oncology unit, but also included the baseline nursing standards for the. And then this was important for us because within this document, the baseline nursing standards were included into the narrative, and specifically for the standards number 1, number 2, and number 3, including, and there was a module, there was a template that countries like Peru, that I will mention this afterwards, will use for developing their own policies on nursing and pediatric oncology services in general. This was an important work led by Dr. Regina Lima and Luis Carlos Lopez Jr. From Brazil, leading this work with all these colleagues and nurses, but also pediatric oncologists and many other colleagues in the region to define and to kind of analyze these essential core competencies for the scope of practice of pediatric oncology nurses in Latin America. And this was a work that I'm really always proud, because this was the first step on establishing what we need and when we need it. And also this document was important to highlight many of the case studies that were implementing the baseline standards in the region, from Chile, from Costa Rica, from Colombia, from Mexico, and many other countries. And also to analyze the possibility of having this collaborative initiatives and support the initiatives from St. Jude, from this is part of some of publications from Miriam Gonzalez, from Asia Gulnik, that reveal us that we cannot work together. We cannot work alone, that we need to support the current initiatives in the region for moving forward. At the regional level, this was an important work, and also I think one relevant aspect is to comment on what's happening at the country level, and also very proud of the work that has been done in Peru with this project of the implementation of the baseline nursing standards for the pediatric oncology units in Peru, particularly in the National Cancer Institute in Lima, Peru. We have pictures of this from the start, and also from the implementation, and now the sustainability phase of this implementation of the nursing standards. So basically in Peru, there were several leaders, nurses leaders that have been part of this work, Rosemary Hilario, Melita Cosme, many of the colleagues from Peru that have been working on first analyze these standards, how they could apply to the nursing practice in Peru. You will see the translation there of the 6 standards, and also how this can become a sustainable work at the institutional level. So you will see also the participation of Kearney, of Sarah, of Lorena in these activities, and Julia, of course, as dedicated mentors in MAFE for this work in a qualitative and quantitative aspects as well. So in Peru, one important aspect was to work on standard 1, that relate to staffing, and that's why this policy was published at a national level from the Ministry of Health, including, as you will see in this table, it's in Spanish, but the idea is that it included the recommendations of the science-based nursing standards into this national policy to assure that the staff based on patients' acuity. So this is something that was very relevant for the work not only in the National Cancer Institute in Peru, but also in many other hospitals at the national level. Also, related to standard number 2, that is related to formalized orientations, we had the opportunity to collaborate as PAHO with the Ministry of Health, with the IPON, and thanks to the mentorship of Julia, basically, but also Lorena and many of the colleagues. Currently, you will see there also Paola Viveros and many other colleagues that have been part of this work to support our colleagues in Peru to at first to be trained in these APON courses in pediatric chemotherapy and biotherapy as participants and as instructors in several, not only in Lima but also in several provinces of Peru, and later on as an online course. And related to standard number 3, the continuing education, this is a word that we're also very proud because we have been able to include this standard and also to potentiate some activities within the country related to education, related to the development of materials for parents that could support nurses into their own practice. Right, when the patient starts therapy or when they needed some support from the medical team or the nursing team for topics like nutrition or hand hygiene or other important items. So this is a publication from 2023 that describes, and you're invited to download it and to search for it. This is a publication from the nurses in Peru, again, with the mentorship of many of the colleagues in this call, that included many centers from Peru, and that were a work including nurses from the Ministry of Health, but also the Social Security and private sector of the country. And you will see all the materials that have been developed since this last 2 or 3 years. With the same methodology, with the needs assessment, with the evaluation from the parents and caregivers of children with cancer, and with the development from specialists in communication and the dissemination of these materials, and also including some specific very Peruvian topics like in Peruvian recipes to support again the medical team and the nursing team to provide this information for parents and caregivers. So this is part of the toolkit that we have been developing during the last years as PAHO and the Global Initiative for Childhood Cancer, supporting member states to achieve these goals, and of course to learn from the experts that are you. And we hope now we have more countries in that line. One example also is Panama, that is developing national guidance for pediatric oncology nursing at the national level, and we're also very, very happy and enthusiastic about that initiative, and also other countries as well. So just briefly to mention all the people and mentors that have been part of this work at the regional level, at the national level in Peru, and of course of the mentorship from you and from SAIAP. I think the work that has been done in this is just an example. I think that I wanted to share with you, and thanks also for the invitation. But I think the impact is way more than that. I think that this is kind of contagious. I always see with different countries that can learn from each other, and they could adapt also these materials and these policies for their own work.
Thank you so much, Liliana, for that demonstration of how you've taken the baseline standards, not only at hospital level, at a regional level, but even at national level as a country, how you've been able to get them incorporated into policies, how you've been able to use them to even advocate in many low middle income countries. We struggle with how to, for example, beat the ratios, the nurse-patient ratios, but you've been able to take these standards and actually use them to advocate. And this really is a tremendous, and really kudos to you and your team. Well done. Our next panelist is Rehana. Rehana is an experienced senior pediatric oncology nurse. She's the director of nursing at Dow Hospital. And so, Liliana, I'm curious to know what you did a tremendous job, at least in Pakistani, the baseline standards, almost all of them have been implemented under your able leadership. What are some of the challenges that you've really encountered in being able to roll out the baseline standards in Pakistan?
Thank you, Mariam. So I will just, Liliana, you did a great, amazing job. You're such an inspiration, and so as well as Glenn, you both are such an inspiration in your areas. So I would just like to go back and, just a flashback little bit that, when we started, we wanted to improve capacity, nurses' knowledge and every pediatric oncology on the whole. So it was 2009 when we received a grant from my Sanofi, Sanofi Spare My Child Matters. And we were really desperate to understand how to really improve the whole capacity building and the whole pediatric oncology outcomes. And then, we were doing trial and errors, and we were on our own, and we were working on our educational system. And then in 2013, when I joined PsyOp, I learned that there is a PsyOp baseline nursing standard. And this was the point when we were really desperate to have some kind of guidelines of what to follow in order to improve the complete outcome. And it was a cheat sheet for us. It was like really a cheat sheet, a checklist of, things to do in order to improve. So that was the time when we started working on it. It took us like more than a decade just in one organization to accomplish all 6 baseline nursing standards. And that was such a big achievement, and we were like really, really thrilled to know that we did everything in that list. It was really difficult, but that standard, that document, the guidelines, only 6 standard, was completely the things that were needed for us to advocate to all our organization that these are the things we need to do. And since it was endorsed from many organizations, it gave us a leverage to advocate more for nurses. And this is how we accomplished. It was difficult. I think the most difficult part was when we were talking about equity-based nursing staffing, 5:1 nurse-patient ratio. In lower middle income countries, there are organizations which I have also known and I have visited and I have trained. The nurse-patient ratio goes up to 1:40 patients, 1 nurse for 40 patients. So, it is very difficult for them to make sure that they have 5:1 nursing patient. But this baseline standard was our key for trying to convince all the administration that this is what is needed. So this was the biggest challenge. The second challenge was to stop the rotation of nurses. And as Glenn mentioned that, once we convinced them to get their nurses trained in subspecialty, and that gave us a leverage that we told them that you do not want to lose these trained nurses and work outside somewhere else, but it's better to get them in just pediatric oncology. The other thing which was like, easier part was developing an educational modules and materials, because a lot of it was us that had to do it. We didn't needed many stakeholders. We knew that we had to develop an orientation program and continuous nursing education, which was 10 hours in a year. So that was something which was something that we didn't depend on many of the other things to do, which we developed ourselves and we maintained that. But the most challenging part, when we achieved all 6 baseline nursing standards, let me tell you again that it was just one organization there where we achieved all 6. The sustainability is the other challenge that we faced. Just maintaining all these standards was so difficult. Once the leadership changed, we started facing problems in maintaining a nurse-patient ratio, non-rotational staff, and continuous nursing education, because the dynamics change, the priorities change. So this is where I think the approach of having this embedded in National Cancer Control Plan would really help. Having a country level standardized approach is something which is recommended and highly appreciated to make sure that it is sustained. And this is why we really wanted Liliana to share her experience, that how did she do this? Because a lot of countries need to follow their footsteps and have this embedded in their cancer control plan. So it is more sustained. The whole baseline nursing, it's not just the achievement, but the sustainability is the key here. So this is the whole story I'm going to tell, Miriam. And now over to you, and we can then, you can take over. Thank you.
Thank you so much, Rehana, for sharing. And the work that you've done in Pakistan with the baseline standard is truly a testament to the greatness in you. And many of us would love to have that in our settings, and we follow your good examples to follow. Now, I would like to open up the discussion to the audience. If you have any questions, please feel free to type in the audience, or you can raise your hand, and then we can move on from there. Courtney, were you going to say something?
Yeah, well, thank you so much to our speakers. It is so inspiring to hear from you related to your implementation of the baseline nursing standards. My question, I know that we are all very familiar with the challenges, which is one of the reasons that the baseline standards were created. My question is for each of you. Oh, can someone mute? Okay, thanks. What about the facilitators? Could you share a little bit about the secret sauce or some of the facilitators to achieving the baseline standards, getting buy-in within your organizations and at the country level?
If I may start, I would say the first facilitator was, let me just say, the wisdom of the core team that began this journey to publish those standards. Because once they were published, as Rehana put it, it was the spark that was required. And then they proceeded with the advocacy for endorsements. The endorsements were also a great facilitator. And then came the Nursing Now movement and the global strategic directions for nurses that was set up by the ICN and the WHO. So we could also advocate using these tools together. Another thing was the coming of the GICC with the Cure All framework, and with some of our countries becoming focus countries for the GICC. Because through this, some funding was coming from St. Jude and WHO to support development of training and safety procedures within our pediatric oncology programs. So the GICC also helped to bring pediatric oncology more to the limelight in terms of government priorities. As we all know, WHO works directly with ministries of health. So whatever project the WHO is implementing is the direct concern of the Ministry of Health. And it made pediatric oncology more prominent nationally. And some of these objectives could easily be adopted by ministries of health. I think those are the few I can cite.
Perhaps if I can also jump in, I totally agree with Rehana. I think to have a published normative or policy, at least in Peru, was essential to have. That was part of the governance aspect, right? To have at least some support at the national level, at the ministry level, institutional level. It's very important to promote political will for nursing in this case, or to include nursing into these policies. It was really important to support also the colleagues from the clinical work, and for them to have this, like some support for them to ask their own chief departments or directors to improve staffing or essential time for or a specific time for making the continuous education or dedicated time for that. So it's important. Also, I would highlight the articulation of stakeholders. I think it's very important, at least for this topic. I think it's important to work together between different to learn to work together from different backgrounds, right? Not only, because during many projects we have been supporting, for example, colleagues in the nursing part with their specific projects and interventions, but if we work together, meaning within these working groups, we have public health experts, but also pediatricians, pediatric oncologists, nursing, psychosocial experts. So all of them given their own perspectives for the work. And that was very important, specifically for the educational part, to receive the inputs from many other colleagues. So I think this articulation of actors are also important. And finally, I think also the leadership from nurses and from different hospitals to at least have at least one or two focal points that could be accountable in these hospitals for each task has been successful so far, and in other activities as well, to have one or two leaders in these activities. Yes.
So for me, the magic juice was the joint goal, the mutual goal with the oncologist, with the pediatric oncologist. When we used to sit with together, we only had one goal, which was improving pediatric oncology on the whole. And being a nurse leader, this baseline nursing standard gave me a really great tool, guideline, checklist. And I used to sit with them and tell them that, our goals are same. You also want to improve the outcomes. We also want to improve the outcomes. So, so joining forces, like Liliana said, getting them, working together with all the stakeholders. For us, all pediatricians, all administration was our biggest stakeholders. So just telling them that these are the guidelines endorsed by so many organizations. It's been read and achieved. So let's try doing this. Let's try accomplishing this step by step. You know, we are on the same wavelength. You also want to improve. So, you know, joining force for one mutual goal was the key for our getting, you know, so much done. So, and other thing was the support, you know, from LMIC, you need financial support to conduct all these things. So, you know, the grants, but also grant was, we kind of, you know, applied for grant on the basis of baseline standards because we wanted to do more. We wanted to achieve these things. So, you know, with that, I think that was our basic passion and, you know, our direction that helped us to achieve this. Thank you.
Thank you so much, our panelists. Are there any more questions? Meanwhile, I would also like to ask, because most of us who are practicing in resource-limited settings, there's always so many competing priorities. So how did your hospitals really overcome some of these resource limitations to be able to ensure that these standards are met and they are put at the center of care?
So again, let me, if I may, I think we all agree there are competing priorities, but then the question is, what are the priorities? Because in Cameroon, for example, when we sat down and did just a SWOT analysis of our pediatric oncology service back sometime in 2017, some of the things that came as top priorities included these nursing issues, which are spelled out in the baseline standards. So if you were to really sit down and, you know, methodically identify your challenges, you would see these are some of the challenges, and there's convergence. They come as priorities for the multidisciplinarity, not just for nursing. Everybody wants that when they prescribe their chemo, the right quantity should be given to the patient. Everybody likes that the patient should be able to get the least side effects from the chemo as possible. So these are some of the priorities. I think that brings me to the point of saying that oftentimes, and it's from a program management perspective, it's usually also limited by funding. Oftentimes we jump into addressing some of these standards without proper planning. But we often, I think one thing which we have learned, especially in Cameroon, is it helps to plan and then implement and then assess, because that's the only way we'll be able to show that what we are doing is creating an impact. And that impact we can use to sell the other needs and see that they are also set as priority objectives. Thank you.
Yeah, I agree. I would add two things that I think were important for Peru, and also to be grateful to the colleagues here, again, Julia, Courtney, Sarah, many of the colleagues that helped us with us, was that continuous communication and evaluation from the mentors, from the experts, international experts. I think it was very valuable for us, because to have the possibility for them to visit countries like Peru, for example, and to give them the visibility. I mean, the nursing staff at the National Cancer Institute, for example, these recurrent calls with the team and with this international mentorship was very important. And of course, the visits, I think, were essential because they were kind of preparing many of the priority. Put this as a priority, because I totally agree with Glenn. I mean, there are many competing priorities. There are many other aspects and sometimes these are very systemic changes for the hospital to address, right? It's not easy changes. So I think it was important. And also, as a second point, I would highlight the possibility to give the hospital, the institution, recognition that could be only virtual or very simple, like a certification of saying, okay, your hospital is making progress in achieving the standards, in increasing the staffing, or setting up programs for education. So that very simple certification or acknowledge for the work that has been done in the hospitals is important. At least it was in Peru and was a very key element of success.
Yeah. For us in Pakistan, if I must say that, how did we manage? There were many competing priorities because, I used to work in a philanthropic organization. So there was like a lot of dilemmas, like, treating more, less patient, cost effective. So there was a lot of debate on that. But in this particular program, we were lucky that we had My Child Matters grant to support us financially. But we were also very smart in our negotiating skills. Like, I think we really played well with everything because, we knew that if we are going to ask a lot, it's going to be very difficult for you. We used to make sure that, we used to work within our resources. Like, we never asked them to give us more manpower or human resource for teaching and training. We never asked them to give us funding for teaching and training. We never asked them, we did it in our own time. We gave extra hours. So, meeting them halfway, trying to make sure that, we are doing this. We are not asking for your support in this regard. So, can you give us this? So this is kind of leveraging the negotiation skills. And, we knew that we can at least, you know, do this part on our own, like teaching training, but we needed 5:1 nursing ratio. So we kind of negotiated them with the skill mix. We did not ask for 5 RNs because 5 RNs would cost more. So we said, we can just have 2 RN and 3 nurse helps, nurse aides, nurse technicians, and we can mix and match. But we would have eventually 5:1 nursing staffing. Like Glenn also mentioned that we trained psychologists, we trained pharmacist technicians, and we had them training go through the whole orientation program of pediatric oncology, just to make sure that they're trained. And once they are trained, it gave us a lot of um, weightage that, now they are trained. So, it's better to keep them here. So this is how we made sure that we retained them. So, there was a lot of strategies we used, but it worked well. So, it has to be passion, consistency, and persistence, I think, you have to be really, really on the goal. So, Liliana will echo me, Miriam will also echo with me that we learned later on that there is work at center. And if you want to make sure, if you focus on work at center, you kind of achieve that goal. So I think this is what happened.
Thank you. And I think you all mentioned an important aspect of communication, of collaboration, of working together in order to achieve this. I think it's becoming clear that you cannot achieve this on your own, but rather as a collaboration within a multidisciplinary team is when you can really achieve to have this implemented and put within the system. And do we have any questions from the audience? Any supplements? Okay, if there are no questions coming, still I have another question that I want to ask. Glenn, you shared that you have these weekly meetings, and through advocating, you're having these nurse-led weekly audits happening in your hospital. How were you able to really to build these collaborations, to improve this communication, to have physicians sitting down and having nurses presenting patients to them and actually listening? And what is some of the impact that this has had on your practice in the hospital?
So I think we talk very often of tax sharing, and it is in the interest sometimes of the oncologists. We have one oncologist per center. That oncologist sees, I don't know, 150 patients, new patients a year. And there are, in Cameroon, for example, we have support with twinning partners from high-income countries. And our oncologist has to sit and discuss new patients with these more experienced pediatric oncologists, on a monthly basis. When it comes to the weekly basis and across centers, to make sure that there is harmony in the care that is given between centers, you can see that it would be burdensome for the same pediatric oncologist to be presenting these patients. So it's all about the teamwork we are talking about. So, but that's not the only side we're looking. We're not just looking at assisting or making the life easier for the pediatric oncologist. The nurses themselves have an interest in doing these presentations because on a weekly basis, they want to be able to see which patient has improved. They want to be able to see which patient's blood count is doing better than last time, which patient with the abandonment rate that we have, which patient has not come, which patient needs to be called. And it's in the course of doing these presentations sometimes, or at least preparing for these presentations, that you realize, oh, there is this gap that we need to face, especially given that there are many patients that each nurse caters for. So I think I've already mentioned some of the advantages that come as a fallout of these presentations. And we don't say it's nurse-led. It's a multidisciplinary team meeting. So it's just a nurse presenting a patient and then the whole team discussing.
Thank you so much, Glenn. We are at the top of the hour. This has been really a stimulating discussion that has really highlighted the importance of the baseline standards. We have seen the success in the countries where they have been implemented. Like they say, a journey of 1,000 begins with just one footstep. I think this is a demonstration that it has been done before, so it can be done elsewhere. And this is an inspiration to other centers that want to improve patient care. The baseline standards have scientific evidence backing them up. The impact has been demonstrated. And with that, I'll say we can end the webinar here. Thank you all for coming. I'm sure this recording will be made available on YouTube. And thank you all for being here.
Thank you. Thank you.
Thank you, Marianne.
Thank you. It was wonderful.